Okay, so we move on to the second presentation. The second speaker is Professor Juan Carlos Kaski. He's the director, Cardiovascular and Cell Science Research Institute, professor at Cardiovascular Science, St. George's University of London. The title of his talk is Gender Differences in Coronary Artery Disease. Professor Kaski, please.
Thank you very much, Mr. Chairman. And I would like to start by thanking Professor Hasegawa for having invited me to take part in this very important ISCP symposium. The topic is absolutely important, and Professor Sliva had actually highlighted some of the aspects of this problem. In the next 15 minutes or so, I will discuss gender differences in ischemic heart disease in women. I have no conflict of interest to disclose for this presentation. Gender differences have been identified in a wide range of cardiovascular diseases over the past decades, including heart failure, as we heard, pulmonary hypertension, vascular remodeling, functional abnormalities in the coronaries, such as vasospastic angina, coronary dissection, and even coronary artery disease risk factors. It is true that coronary artery disease develops 7 to 10 years later in women than in men, but it is the major cause of death in women. The risk of coronary artery disease in women is very frequently underestimated. Very importantly, due to the misperception that females are protected against it. The under-recognition of ischemic heart disease and the differences in clinical presentation in women compared to men had led to a less aggressive treatment strategies in women and the lower representation of women in clinical trials. And this is a reality that we need to change. Very importantly, there is a problem with the self-awareness in women and the identification of the risk factors which need more attention. As I'm pretty convinced from data in the literature that in doing so, we will be able to carry out a better prevention strategy of cardiovascular events in women. Undoubtedly, cardiovascular disease remains a leading cause of morbidity and mortality in women, despite the overall reduction that we are seeing in mortality in recent years in the field of cardiovascular disease. Lifetime risk of cardiovascular disease in women is very much linked to what we call traditional, conventional risk factors, such as hypertension, increased cholesterol, smoking, diabetes. Very importantly, as with men, coronary risk factors are multiplicative. And you can see that those women who have very little in terms of risk factors at age 60 end up having not very many cardiovascular events over time, whereas women with 2 or more major conventional risk factors will have a fairly high incidence of coronary events, so their cardiovascular risk is clearly increased. But interventions that affect 1 or 2 modifiable risk factors will actually improve the situation quite dramatically. And I have listed here, and because 15 minutes is a very little time to actually cover the whole field exhaustively, I have listed here a few important points that I would like to mention for you to go through them in your own time. Women with clinically manifest coronary artery disease tend to be older than men with more risk factors, but the relative weight of these factors is different in women. At younger ages, for example, smoking, which impairs estrogen-related vasodilatation, is more deleterious in women than it is in men. In other words, they have a higher risk of developing a first acute MI. The other thing we see is that BMI increases and metabolic syndrome often develops rather quickly after the menopause. And there is also an increased prevalence of type 2 diabetes. And we know that women with diabetes are at a greater risk for cardiovascular complications than men, with a 50% higher risk of fatal coronary artery disease events. The other important thing that we see in women is that there is a steep rise of systolic blood pressure in aging women compared with men. And after the menopause, there is an upregulation of the renin-angiotensin system, soil sensitivity and sympathetic activity, which lead to, or potentially lead to, cardiovascular events. A very important component of this process is endothelial dependent vasodilatation, which is impaired in postmenopausal women. And cholesterol, LDL cholesterol raises as women age. Lp(a) also increases. And there is a large Japanese study showing benefits of statins in primary prevention in women. So there is the possibility of counteracting this process that is linked to the aging in women. The menopause plays an important role in the development of ischemic heart disease in women. Endogenous estrogen during the fertile period of life delays atherosclerotic disease in women. They promote vasodilatation, regulate lipid metabolism, inflammation, and coagulation. And before the menopause, coronary heart disease event rate in women is relatively low and mostly due to smoking. But very importantly, a study by the WISE program in the States have shown that young women with estrogen deficiency have a greater than 7-fold increase in the risk of coronary artery disease. That is simply associated with estrogen deficiency. And women with an early menopause, before 40 years of age, have a 2-year lower life expectancy compared with women who have a normal or late menopause. So menopause playing a major role. The other important observation comes from anatomopathological studies. For example, this one from Reno Virmani and colleagues, showing that young women tend to have plaque erosion that may lead to acute coronary events, and older women have more plaque rupture. So there is a difference between men and women regarding the composition of plaques, but also there is a difference between younger and older women. And the plaques of premenopausal women have relatively little necrotic core and calcification compared with postmenopausal women and men. And this is important in terms of what determines the progression of the disease. And Reno Virmani has highlighted the importance of the menopause because the incidence of plaque rupture is higher in postmenopausal women compared to younger women. And there are some particular aspects of these anatomopathological characteristics that I have no time to share with you today. There have been some studies looking at gender and extent of coronary atherosclerotic plaque composition and clinical outcomes in patients who had developed an acute coronary syndrome. And in general, the studies have agreed that women, compared with men, have less plaque rupture and less necrotic core. They do have smaller lumens and similar plaque burden. And very importantly, thin cap fibroatheromatous plaque is a very strong marker of plaque vulnerability, more in women than in men. And the highest risk is clearly associated with this type of fibroatheroma in women compared with men. And there has been a strong association between increased major adverse cardiovascular events risk and non-obstructive coronary artery disease in women, and of course in men. But this is an important concept. Not only obstructive coronary artery disease, which is more prevalent in men, has an important role here, but despite women have or are being more likely to have normal coronary arteries, there is a very strong association between the risk of events and non-obstructive coronary artery disease due to abnormalities in the function of the coronary vessels, both the epicardial and the microvessels in women. And very importantly, and this is something that we tend to neglect, there is subclinical coronary artery disease in women with angina pectoris. Women who present with an acute MI or angina are twice as likely as men to have microvascular angina and no obstructive coronary artery disease. But when one looks into the arteries of these women using IVUS or more recently OCT, one sees that there is a very important burden of atheroma in those lesions, which may not obstruct the blood flow, but can actually make the arteries behave very abnormally. So these are the differences, but we have other problems, and which seem to be taking us in the wrong direction regarding the way we diagnose and treat ischemic heart disease in women. We seem to be going in the wrong direction. And this is essentially because of an under-recognition of heart disease and, very importantly, of the differences in clinical presentation in women, which leads to less aggressive treatment strategies and the lower representation of women in clinical trials. I have actually mentioned two important studies, which may look a little bit old now, including the European Heart Survey in 2005 and the National Health and Nutrition Examination Surveys of 2009. But unfortunately, things have not changed that much. And one of the things we tend to neglect is that although traditional risk factors for cardiovascular disease predict risk both in men and women, there are risk factors that are unique to women and related to their reproductive history. And they have a very important role. Polycystic ovary syndrome, premature ovarian failure, surgical and spontaneous menopause, gestational diabetes, they can all affect the development of cardiovascular disease later in women's lives. Therefore, the assessment of cardiovascular risk in women should not just focus on conventional risk factors, but also on the different aspects of the gynecological history of these women, which would allow more specific preventative and therapeutic strategies to be established. Something that we cannot ignore is the fact that coronary microvascular dysfunction is more frequent in women than it is in men. And this has been identified in a number of conditions. And coronary microvascular dysfunction has gained increasing attention in recent years because it's the highly prevalent condition, and it affects clinical outcomes in women and also in men, but very importantly in women. And recently, Professor Shimokawa's group in Japan has actually shown how endothelium-dependent hyperpolarization mediated vasodilatation is more prominent in female resistance arteries, where estrogens exert beneficial effects on endothelial-dependent vasodilatation via different mechanisms. So the understanding of the difference in the coronary physiology, and particularly the physiology of the endothelium, is important to understand the different clinical presentations and outcomes in women with angina. We knew that microvascular angina was present in a larger proportion of women than men for many, many years. We used to call these patients cardiac syndrome X. We now identify that this is microvascular angina, a condition associated with abnormal coronary microvascular function. And this is very important because coronary microvascular dysfunction in women and also in men, but in women in particular, as shown by the WISE project, indicate that these women with abnormal flow reserve, despite no obstructive coronary artery disease, tend to have impaired clinical outcomes over time. And this has been confirmed by studies in both men and women, invasive and non-invasive tests. And I will not spend any time on this. I just wanted to endorse what we heard before. Heart failure is an important problem in women. There is a higher prevalence of heart failure with preserved ejection fraction in women, perhaps linked to coronary microvascular dysfunction. There is also a different response to treatments in women compared with men. And we are seeing also differences in mortality associated with ischemic heart disease and stroke in women and men. There are lots of unknowns in terms of stroke, and I will not dwell on this, but just to raise your sort of attention to the fact that mortality from coronary heart disease and stroke remain higher among men, but also among women. And again, as shown by Professor Sliva, cardiomyopathies may affect differently the different genders, and a lot of work is required here in order to understand the differences, the gender differences. So, and these are my last few slides just to reinforce the fact that cardiovascular disease is the leading cause of death in women globally and leads to a similar number of deaths in men and women. The failure to recognize the prevalence of ischemic heart disease in women and the different symptoms during an acute MI continues to contribute to the loss of vital time. And women, unfortunately, get consistently worse care, with women receiving less antithrombotic agents, or are transported to acute centers more slowly than men. So in summary, I think that gender differences have been identified in a wide range of cardiovascular diseases. Cardiovascular disease is the leading cause of death in women globally. The historic failings of cardiology to take a balanced approach to research have led to fundamental flaws in the care for women with ischemic heart disease, and it may have cost lives. Despite more comorbid risk factors than men, women have less extensive coronary artery disease, but they have more microvascular dysfunction with poor outcomes. And as I said before, plaque morphology and composition differ in men and women and in younger and older women. Thank you very much.